Yes, it's visible now.
Okay. So, good morning, everyone. Myself, LIPSARANI Saho, a second semester student at Locho Netrala School of Optometry, which is affiliated with the Odisha University of Health Sciences. So, today I will present on the topic Horner syndrome. So, these are my content that I will cover in today's session. I will start my presentation with an introduction, then followed by anatomy, causes, epidemiology, classification, types, clinical significance, rare and transient feature of Horner syndrome, diagnosis, treatment, and at last I will conclude my topic with conclusion. So let's discuss about Horner syndrome. So Horner syndrome is also called as oculosympathetic paresis, which comprises a constellation of clinical signs, including the classic triad of ptosis, which is the drooping of eyelid, and miosis, which is the constriction of pupil, and anhidrosis, which is the lack of sweating. So it is result from a lesion to the sympathetic pathway that supplies the head and neck region. So the cause of Horner syndrome varies with the site of action. So before move into the Horner syndrome, we have to first clear the anatomy. So this is the sympathetic pathway. So the sympathetic pathway is the three order neuron pathway. From the first order neuron begins at the posterior lateral surface of hypothalamus, and it descend on crust. Then the sorry. Then through the brainstem and reaches to the C8 to T2 level of spinal cord. So the C8 to T2 level of spinal cord is also known as also known as the ciliospinal center of Watch. So the first order neuron are also known as the preganglionic neuron. From the ciliospinal center of Watch, the second order neuron arises. And so these are also the preganglionic neuron, because the nerve fibers do not have synapses yet. So sympathetic nerves are closely related to the apex of lungs. So this anatomy is important to know, because the lesion in the apex of lungs or pleura may affect the sympathetic pathway. Then the third order neuron exit from the internal carotid artery and the cavernous sinus, where they joins the ophthalmic division of trigeminal nerve. So the sympathetic nerve also contain the vasomotor fiber, which which maintain the tone of blood vessel, and pseudomotor fibers, which maintain the sweating, and the pupillomotor fiber, which may control the tone of the pupil. So through the internal carotid artery, the pupillomotor fiber continue, and the sympathetic fiber reach the ciliary body, and the dilator pupillae muscle via the nasociliary nerve and long ciliary. So the causes of Horner syndrome include the first. So the first order neuron causes includes the brainstem stroke, that is especially the lateral medullary infarction, then brainstem tumor, demyelinating disease, syringomyelia, which is nothing but the fluid filled cyst in the spinal cord, and Wallenberg syndrome, and the cervical spinal cord lesion, diabetic autonomic neuropathy. And the second order neuron causes includes the pancreas tumor, carotid aneurysm, aortic aneurysm, dissection, thoracic spinal cord lesion, neck trauma, thyroid tumor. And the third order neuron causes includes the internal carotid artery dissection, nasopharyngeal tumor, cavernous sinus mass, otitis media, cluster headache, etc. So let's discuss about epidemiology. So Horner syndrome is uncommon and rare cause. So there is no predisposition between age, race, and gender. So in a population-based study, it is found that the incidence of Horner syndrome was estimated to be 1.4 per 1 lakh patient as less than 19 years, with a birth prevalence of 1 in 6,250 for those with a congenital onset. So 1.4, so in incidence 1.42 per 1 lakh patient is that are less than 12 years, and in birth prevalence there is 1 in 6,250, but in 1 lakh there are 16 per birth. So the classification of Horner syndrome. So the Horner syndrome is classified into three groups, that is congenital, acquired, and hereditary. So congenital is occurs in infancy and in between the age of 2 years, and acquired it occurs due to any vascular lesion and tumors and neurological disorder, etc. And hereditary is very rare with hereditary autosomal dominant. So there are four types of Horner, that is central, peripheral, preganglionic, and postganglionic. So the central Horner is the first order neuron. If the first order neuron are affected, these are known as the central Horner. And if the second and third order neuron are affected, these are known as peripheral Horner. And the preganglionic Horner occurs when the lesion are present before the fiber synapses at the superior cervical ganglion. So basically the first order or second order lesion. And the postganglionic Horner, it occurs when the lesion occurs after their synapses um, at the superior cervical ganglion. So the clinical significance of Horner syndrome. So the classical triad describe the clinical significance of Horner syndrome. So let's discuss about one deeply. So first, ptosis. So ptosis is nothing but the drooping of eyelid. Then meiosis. So meiosis is the constriction of pupil, and the anhidrosis, which is the lack of sweating. So let's discuss about one is deeply. So let's discuss about meiosis. So meiosis is nothing but the constriction of pupil. So pupil is constrict due to sympathetic innervation. It is caused by mainly the on or post action of sphincter pupillae muscle. It produces anisocoria. So anisocoria is more obvious in dim light, and the light and air reflex remains normal. So basically, meiosis in Horner syndrome is constricted pupil caused by the loss of sympathetic innervation, which resulting in a smaller pupil and anisocoria. So I have a question for everyone. So can we directly say that patient with anisocoria has meiosis? You can just type in chat box. I think there is no answer. So there is no, because anisocoria may happen for other reason also, and meiosis is one of those reasons. To confirm that anisocoria is due to meiosis, we need to examine the pupillary action of this eye in both bright and dim light. Hello. Here you can see, so let's discuss some cases. So in dim light test for meiosis, in case one, I am referring the direction for examiner purpose. So if this is the patient, let me laser point. So if this is the patient right eye, this is the small, this is the bigger, and this is the smaller. So here you can observe that the normal eye with proper dilated pupil in dim light and the defective eye with the constricted pupil in dim light. So from this observation, we can conclude that the anisocoria is more visible in dim light and the sympathetic pathway is defective, so meiosis is observed. And here you can see the right eye pupil is dilated and the left eye pupil is normal. So here you all can observe. So the defective eye is already dilated pupil and the normal eye with proper dilated pupil in dim light. So from this we can say that the anisocoria is not visible properly in dim light, but it is visible before exposure to dim light. So the sympathetic pathway, so the here sympathetic pathway is fine, but fine maybe, but parasympathetic pathway is defective, so meiosis is not observed. So in bright light, here you all can see this, this is the larger and this is the smaller pupil. So what we are observing here, so so this is the normal eye with proper constricted pupil in bright light. So in these cases, we can observe that the defective with already constricted pupil in bright light. From this, we can from this we can conclude that the anisocoria is not visible properly in bright light, but it is visible before the exposure to bright light. So the parasympathetic pathway is working. So here the parasympathetic pathway is working, maybe or sympathetic pathway is defective. So meiosis is observed on the defective eye. In case 2, we are observing that here this pupil is smaller than the left pupil. So here we can observe that here the pupil is proper constricted in bright light, but here the pupil is already dilated, but there is no constriction in bright light. So from this we can conclude that anisocoria is more visible properly in bright light, but here the parasympathetic pathway is maybe defective, that's why the meiosis is not observed. So let's discuss about the ptosis. The sympathetic pathway innervates the smooth muscle of the upper and lower lid. So the upper lid smooth muscle are known as the molar muscle. The molar muscle causes the lid elevation. So lid elevated about 1 to 2 mm. So that's why the mild ptosis occurs. That is also about 1 to 2 mm. The inferior eyelid, so the inferior eyelid shows reverse ptosis or upside down ptosis, then anhydrosis. So anhydrosis is nothing but the lacking of sweating. So the anhydrosis, there are three type of anhydrosis can be seen in Horner syndrome patient. If there is defect in first order, if there is in the first order neuron lesion, the ipsilateral face with the ipsilateral half of the body can be affected. In second order neuron lesion, the ipsilateral face will be affected, and in third order lesion, there will be no anhydrosis or small patches on forehead will be affected. So, what are the other ocular significance that can be found on Horner syndrome? That is the iris heterochromia. So, iris heterochromia is nothing but the two eyes iris is different in color. So, it's mainly found in the congenital Horners or acquired Horners before the age of 2 years. And the iris pigmentation is also under the control of the sympathetic pathway. And let's see what are the rare and transient feature of the Horner syndrome. So increase in the accommodation and decrease the transience hypotony is nothing but the decrease in the intraocular pressure. And some patients come with the redness of eye with ptosis, meiosis, and anhydrosis, etc. And change in the tear viscosity and asymptomatic flushing of face. Then symptoms. So what are the symptoms that the patient can feel? So reduce in the superior visual field. If the patient look for upward, the patient can feel difficulty in uh, in his upward direction. So difficulty in seeing in dim light and delayed dark adaptation due to impaired pupillary dilatation, difficulty while driving at night or walking in poorly light areas, and increased in the visual discomfort when moving from bright to dark environment. So diagnostic. Diagnosis is two step. We can confirm it's Horner syndrome by pharmacological test and from image testing also. So why we will do the pharmacological test? So we will the purpose of pharmacological test is to confirm it is whether Horner syndrome or not, and to differentiate whether it is preganglionic Horners or postganglionic Horners. So let's see what are the pharmacological tests available for Horner syndrome. So apraclonidine, cocaine, hydroxyamphetamine, phenylephrine, adrenaline. So let's discuss each test deeply. So apraclonidine test. We have to put 1 drop of apraclonidine in both eyes. We have to check for 30 minutes. If result is unclear, check again after 45 minutes. This test help to confirm or rule out the Horner syndrome. The test usually become positive about the 7 days after nerve damage. So this test is not used in infants because this can affect the brain. We have to avoid the other pupil drug test for 3 to 5 days. Apraclonidine because it affects the last a long time. Then cocaine test. So we have to instill the 4% of cocaine drops in both eyes. It is used to confirm Horner syndrome. In a normal eye, the pupil dilates. In Horner eye, there is no dilatation. No dilation. This test is rarely used today because cocaine drops are difficult to obtain. Usually it used when the Horner syndrome is acute, or the apraclonidine test is inconclusive but suspicion remains high. Then let's see about the hydroxyamphetamine test. So we have to put 2 drops of hydroxyamphetamine in both eyes. So it is used to find the location of nerve damage in Horner syndrome. It helps to differentiate the preganglionic or postganglionic Horner syndrome. It is slightly more sensitive than the phenylephrine test. A, a normal or preganglionic Horner will be dilated. A postganglionic Horner pupil will not dilate it. So the first and second order neuron will be dilated, and the third order neuron will be not dilated. The drug release non-adrenaline from the healthy postganglionic nerves. If the postganglionic nerve is damaged, the noradrenaline is not released. So therefore, the pupil does not dilate in postganglionic Horner syndrome. So it helps to localize the site of lesion. So let's see about the phenylephrine test. The phenylephrine is used to differentiate the preganglionic and postganglionic Horner syndrome. So it has largely replaced hydroxyamphetamine and adrenaline test. It is most readily available and gives similar result. So it marked the pupil dilatation, suggests a postganglionic lesion. In postganglionic Horner syndrome, the pupil will dilates and ptosis may temporarily improve. A normal pupil or preganglionic Horner pupil show little or no dilatation. So this is due to the denervation hypersensitivity of the dilator muscle, and the adrenaline acts similarly to phenylephrine. So there are two types of image tracing we can suggest to do for patient. So CT and MRI. In CT and MRI, we can see the tumor, lesion, etc. in patient's reports. So what are the treatments for Horner syndrome? So there is no specific treatments for Horner syndrome. The neurosurgical attention for aneurysm related Horner syndrome. And we can suggest the patient for vascular surgical care for the cause such as carotid artery dissection or aneurysm. And how can we manage the Horner syndrome? First, we have to treat the underlying cause, for example, carotid artery dissection. We have to refer the patient for urgent vascular treatment. And in tumors, we can suggest the patient for surgery, chemotherapy, or radiotherapy, etc. And in stroke, aneurysm, and neurological disorder, the appropriate and medical surgical management can be required. And in ocular management, the mild doses does not require treatment. If doses affect the vision, the surgical correction may be considered. Patients who are dissatisfied with the cosmetic appearance of ptosis may be offered ptosis surgery to improve the facial symmetry and appearance. So, at last conclusion. So, Horner syndrome occurs due to the interruption of the sympathetic nerve pathway supplying the eye and face. The classical sign includes the ptosis, miosis, and anhidrosis on the affected side. It may develop because of neurological, vascular, traumatic tumors condition. So identifying the cause is very important. So the early diagnosis and proper investigation help in detecting the serious underlying disease and improving the patient management. Timely treatment and underlying cause can reduce the complication and improve the patient quality of life. So these are the reference I have taken. Thank you. If anyone have any question, they can mail me. I will get. I will reply them.
Thank you, Lipasarni, for that excellent and informative presentation. Your explanation of Horner syndrome, its pathology, and all was very well presented and easy to understand. Thank you for your efforts and contribution to this learning initiative. So now I would like to invite our respected panelists to share their valuable observations and feedbacks. If anyone have any questions, then type in the chat box and get their answers as well. Now, I would like to invite our respected panelists to share their valuable observations and feedback. First, I would like to invite Ms. Varsha Singh ma'am, Assistant Professor at KD Institute, to provide her comments and suggestions.
Good morning, everyone. So, Lipsarni, you have presented very well. Explanation was so good. You were so confident while presenting. And that's all. Just best of luck for me. For me to get selected for any other opportunity.
Thank you so much, ma'am. If anyone have any questions, then type in the chat box or mail her. So, as we come to the end of the today's session, I would like to thank you, our presenter, who is Lipsarni. Thank you so much, Lipsarni, for your insightful session. Very well presented. Our esteemed panelist, Varsha Singh ma'am and Mohammad Asad sir, and our founder of NeuroOptech, Adnan sir, and all participants for their active presence and support. A special thanks to Mr. Mohammad Adnan sir, who is the founder of the One Day One Syndrome Challenge, for creating this wonderful learning platform. Knowledge grows when it's shared, and today's session was another step towards becoming better healthcare professionals. Thank you everyone for joining us. Have a wonderful day ahead.
Thank you. There is a question, what is anhydrosis? So anhydrosis is the lack of sweating.